Okay, thank you, Dr. Lanier. So we're going to bring up to the stage Dr. Paul Fulmer. Dr. Fulmer is a board-certified otolaryngologist, head and neck surgeon, who has over 30 years experience. I think the last 10 to 12 have been sinus and nasal treatment, and he's a fellow of both the American Academy of Otolaryngology, head and neck surgery, as well as the American College of Surgeons, and a member of the Texas Medical Association. So we will
That's a lot.
it off to you.
You know, all that just costs money. You just pay every year, and they keep it up. So I'm one of the ENT surgeons, and I go to Midland, Waco, San Antonio here, El Paso, and Corpus. And Chris goes to the other places right now, and we've known each other quite a while. So we're going to talk about surgical, how to manage the polyps. Oh, where'd you put the remote? Is it up here?
Oh, I'm so sorry.
Are you going to do this? The big green arrow is forward. The big green arrow.
Yeah. And that is the, that's the forward.
Mm-hmm. There you go. All right, cool. So if we never had to do a nasal polypectomy again, we'd be happy. I mean, this is not something that we're excited about. It's clearly that it's from doing just a balloon sinuplasty to this, the risk of bleeding and everything goes way up. And since we're working in the office, we like to kind of evaluate the patients, and we'll kind of go through that today as to what we consider appropriate for in the office, what we can maybe stretch and do a little, and what we may not be able to do in the office also. So what are polyps? Well, polyps are really just how the lining in your nose reacts to the world. The majority of them are from allergy, but sometimes the polyp is there, especially with unilateral, because the sinus behind it's blocked, and you don't know which came first, the chicken or the egg, and it's got chronic infection, and that's created a polyp. The nice thing about those is that if we clear that out, often they won't come back compared to where they have polyps everywhere. Often that's how they're reacting to the world, allergy, and subsequently those often do come back, as we just heard. Let's see. What do? They obstruct the outflow tracts, and anosmia is a big deal that, makes, just like he mentioned, that, make your kind of antenna go up that they probably have polyps. And then it can make the sleep apnea a lot worse. Nasal obstruction, anosmia, sinus pressure, headaches, foul drainage, often because it's trapped in there. It can also often become anaerobic because it's been in there a while, and it makes the OSA worse, subsequent fatigue, malaise. So when you've tried all these things that we just heard about, then they get punted over to us, and we're like, okay, let's see how bad this is. Usually we always start with steroids, oral steroids, nasal steroids, and now biologics. When things are localized to just the ostomeatal complex, we have a lot better chance of trying to eliminate this problem at the same time that we're doing a balloon, sinuplasty, or any sort of other procedure where we're going to open up the sinus. And then there's something called an antrochoanal polyp, and that's usually one-sided most of the time. It's coming out of the maxillary sinus. It's where it originated, and it's slowly grown through the ostomeatal complex, and it's back down in the nasal vault, and often goes all the way back to the back of the nose. They can be pretty impressive. One of the fun things we did when we were residents is we'd have one of those in there, and we'd have a younger resident in there that had never seen this, and so we could get these really kind of not sharp instruments and slowly pull it out the nose. And we just keep working on it. And you pull out this thing, like this big, and they're going, what the? But anyway, that's a little sidebar. So, we had to keep it fun, right? And then there's extensive polyps throughout the sinuses that I'm going to show a few pictures for that. So I hope this works here. Yeah, good. So this is just going to show extensive polyposis in this sinus where everybody can see it's completely whited out all the way through up into the forehead. So somebody like that, and I actually think this one is too, people like this, I'm going to hammer them for 3 weeks with steroids, antibiotics, and have them come back and maybe do another scan. If it looks the same, in my opinion, it's too extensive to try to do in the office because it's just, you have to go all the way through ethmoids up into the frontal, into the maxillary, into the sphenoid. We have some different things we can do in the operating room that we can't do in the office, which is surgical mapping, because polyps basically obliterate your landmarks. Let's see if I go back to this. You can kind of see as you go through. Oops. I'll try to run it again. I guess it won't let me. Anyway, and so the landmarks that we use to kind of see and know where we are in the sinus when we're operating can just get blown out, pushed away, and then the risk to the brain and the eyes goes way up. And so that's why we'll have these different techniques where you can have surgical mapping, where you can kind of marry the CAT scan to the patient in the OR, look at it on a screen, have instruments go in. It shows you within 2 millimeters exactly where you are. And those have gotten a lot better. And for somebody who's extensive like this, sometimes I'll lean toward having somebody do something like that locally with an ENT. Chris and I differ a little on that. I think you're a little more willing to give it a whirl, is that right?
Well, I would just go to the OR here.
Yeah. I just I'm never in a place where I can go to the OR. I'm always, yeah. Yeah, it's about patient safety, you know? I mean, and that's really what it comes down to. And it's not like we see 20 of these a month. You know, so in my mind, it's the one, a couple, a quarter or something that we may have to refer out. So I look like we're missing a lot of things. And it's the right thing for the patient. So a unilateral polyp that's in the osteometal complex is perfect for what we do. And I think this one, I wish I could stop this, but I have a light, don't I? Kind of right in that area right there. And so and there's kind of infection behind and in the maxillary. So if we can get that area open and then balloon and open up the ostia really well, clean all that out, often that'll be the end of that for that patient. And we won't have to have them on, steroids or have to worry about it coming back. I think I have another picture. I think this is Chris Barty sent me that. He sends them pretty fast. I had to go, pause. But,
Is that why the prohibition for unilateral versus bilateral is in there for insurance companies, that they are looking more at a polyp that is cured by surgery?
are they against that? Is that what you're asking? Unilateral? You think they're against unilateral? Is that what you said? No.
Well, they want a bilateral before they'll approve a biologic.
Yeah.
Is the basis of that thinking because?
I don't know what their thinking is. I mean, really, that makes sense because they're thinking, oh, well, you could probably fix this with surgery, but insurance companies, basically it's just to say no. I mean, that's, especially for us. Another one of these, I believe. Yeah, see right in that area right there. And so you can see how and I'm going to show you the little machine that we use to open that up with here in a second. Oh, this was Chris's. Whoop. But you could see it it was on this other side over here. Huh? Yeah, that's perfect, yeah. So I know where to go. And then here's somebody who has extensive unilateral polyps on this left side. And you'll notice it pushes the septum over, it'll push the orbit a little bit. And anytime I see something like this, I'm kind of also worried about inverted papilloma or some other kind of tumor or cancer. So I'm really cognizant of that. I'm really looking at the bone landmarks on the CAT scan to see if it's eroding into the orbit or up into the frontal or something along those lines. So you can see it's mainly on this side, but look how big that thing is. And it goes all the way back to the choana in the back of the nose. So that is, that would be a challenge, let's put it that way, for us. And if I get in there and it's real gritty and hard and starts really bleeding a lot, I'll probably just biopsy it. because there's a good chance it's going to be something that needs a more extensive surgery anyway. But sometimes you get fooled. You get in there, and I had one that was about this big, and when I kind of got around it, it had a little stalk coming off, and I was able to cut that and went in the back. We reached in the mouth and pulled it out, and that fixed the problem, you know. So it was an older lady. So this is kind of what I do pre-op: doxycycline, augmentin, anything that covers a lot of things, and then prednisone. I do 5 days, 5 days, 5 days is the way I like to do it. But Chris, what do you do? It's a little shorter.
7 days, but I start with 60.
Yeah. So.
60 for 3, then 40 for 3, and usually by the time.
Yeah. Yeah. And so those people who were terrible, I'd do this for 21 days, have them come back, do another scan, look at it, see if we, sometimes it's dramatic. A lot of it wasn't polyps, it was infection block. Things got a lot better. Now they just have polyps in certain areas. I'm like, let's schedule them. And then another thing I do, I don't know if you do this, is like if I know it's gonna be about a month, I'll put them on like 10 or 20 milligrams of prednisone every other day. And it keeps it kind of calmed down. And the side effects go way down because we're not giving it to them all the time. It's usually 10. And I've noticed when I see them, you know, like when I'm getting ready to do the procedure, it's still pretty calm, which allows us to, because a lot of those people need something right then. They're miserable. So you hammer them, and then it's like, okay, well, we can do you in 2 months on a Wednesday, you know, and they're like, well, and if you don't do anything, then we can't really, I mean, we get in there, it's just a mess. But if we can keep it all calmed down. And so that's one thing. If you're at a venue where we do these, I try to do this anyway, but 2 weeks out, you might want to just look through the people on the list and just kind of click on them and see, okay, well, this guy had a lot of polyps or whatever. Look back, see if you've been treating them. If you really haven't and it's been a month or two, or maybe hit them with another round right then, and not instead of hoping that triage, or I don't know. I mean, it's an easy way to do it because a lot of my places, I'm there once a month, okay? So this isn't like something you have to do all the time. And if you look at it a couple weeks ahead and go, okay, well, this person clearly has polyp problems. We already hit them good. They got a little better. Call, maybe talk to them. Yeah, I'm starting to feel like I did before. Well, then boom, hammer them with this kind of thing, where it finishes kind of right as we're going to do the procedure. They'll just have a better result. We'll get a better job done, and the patient's going to feel better and heal a lot quicker. So this is what the little machine looks like. And so this really came from doing knees for ortho. And they just made it a little smaller. Oops. The end is blunt. So we can use that actually to poke into like an ethmoid or something. And then the blade is right in here and it has suction on it. So it's vibrating like this. And so when we get it up against the polyp, it sucks the polyp into the opening and then cuts it. So it's a lot less bleeding. We're not reaching in and grabbing and pulling and bringing all this other stuff that doesn't need to come out. So we both love this because this changes the whole game on this, where we can really get specific on how much we take out and get it as open with trying to minimize bleeding and things like that. Excessive bleeding, brain injury to your orbit or your brain. I mean, that's right where we're working. That's where we live. And then even post-operative bleeding where they come back. Usually on something like this, if it's going to bleed, it's going to do it right then on polyps, unlike other types of bleeding. But sometimes it doesn't later. So what's the benefit? Like I said, isolated polyps it's great for this, or if it's just blocking certain sinus outflow tracts, and we can see that on there, we're going to get better airflow. Dramatically, people talk about their smell and their taste improves once you get airflow up by the olfactory nerve again. If it hadn't been too long. Some people are just out because they were blocked for years. OSA can even get better, sleep, energy levels. And that's that. Any questions? Yep. I don't think that's a bad deal, but if they're pretty bad, it's not even getting back to all of it. That's why we do PO steroids. But you can do both. And it's not a bad thing if you've hammered them to already have them on that, and so then that's maybe topically helping it too, along with my little every other day thing. Seems to work. Probably not, because even the first one, if it's blocking the openings, it's going to get the bacterial behind it a lot of times, where it's blocked the sinus off, because we're making mucus all the time and we can't get out. It's a perfect environment to set up an infection. So I don't know how you would be able to, the patient would be able to describe some symptom that would be able to differentiate that. That's why you biopsy. Yeah, biopsy or something. But I don't know. I mean, do you know of a symptom that the patient would describe? That would, yeah. All right. Thanks. Oh.
One comment regarding sinus strictures. Comment before patients having recurrent sinus disease, the bacterial infection like Streptococcus. We're talking about evaluating the study for hypermetabolism specifically antibiotic.
Yeah, definitely. Maybe before.
Yeah. Well, that's why I started the talk with, if we never did another polyp case, we'd be fine. Because, yeah, you do it, what looks like look awesome, and so that's why they need to be treated for allergies.
Yeah.
Because that's often the root cause, and if we're not slowly treating that, then we're just operating, or we're doing Dupixent or something, you know what I mean? It's,
Yeah, I always make sure they're at least tested. They always have refill on their topical meds.
root causes.
And I like for them to come in every 3 months.
Yeah.
Get polyps to just, because if we catch it early, it's pretty easy to take care of it.
You know, one thing I didn't mention, but polyps really can erode into the brain. They can really erode into the orbit. I've seen that in a 7-year-old before. I mean, I've seen it in all different ages. So that's why we don't just say, oh, well, they've had them, let's not worry about it. And that's why when I'm looking at those scans, I'm following the bony outline of the cribriform plate and all the, when I'm, you know, reviewing that, because everything's gray. And I've seen it all the way into the, you know, like I said, in the brain or the orbit. So it's
Because of pressure necrosis.
yeah, just slow, and it's,
Vascular supply, that's how that happens.
yep.
I've been noticing, I don't know, since I've been here for a while, I don't know if it's just picking up on it more, but kids, a lot more kids.
With polyps,
Polyps.
yeah.
Sometimes they're established patients of ours when we've been on allergy immunotherapy, and we're following up on that. And I'm asking them, like, what's your top symptom? And they're like a teenager.
Yeah, nasal
They have
obstruction.
sinus
Yeah.
in there, they have nasal polyps, you know.
It may have just progressed enough that now you can see them, whereas before it was, you know, not as much, and they're still having the allergies that you're trying to treat. And I suspect it's probably just gotten big enough where now it's causing a bigger problem. And it may have been there before, but they were little, and you're not going to get a scope up in there probably very easily.
How much are you guys seeing, like the incidence of nasal polyps and kind of like functionality? I've been noticing more studies on like ADHD because of allergies and things like that. It's interfering with their lifestyle. Have you guys been seeing more like nasal polyps and sinus issues in kids, or it's just the same as usual?
Yeah, I haven't seen it to uptick or anything. All right.